Through these conversations, it allows us to signpost to community resources that enables a person to get the help they need. They might come into the hospital with one thing, but we can ensure then that the holistic person is looked at by integrating with our community supports.
Hello and welcome to the HSE Talking Health and Wellbeing podcast. Today we're talking about Alone and the ECC programme, the Enhanced Community Care programme in the HSE. Our guests today are Catriona Brennan, a candidate Advanced Nurse Practitioner, Frailty, Gail Flynn, Advanced Nurse Practitioner, Older Persons, and Aileen O'Reilly, Head of Research and Evaluation and Policy at Alone. You're all very welcome to the podcast.
Thanks very much, Fergal. Great to be here.
Thanks a million.
Okay, so we're focusing on the work of Alone in collaboration with the ECC programme in the HSE, and you've been telling me about some of the partnership working that's been going on in this area. I know a lot of our listeners will be familiar with Alone, and some of our listeners may be familiar with ECC, but let's just set a baseline there. Aileen, can you tell me first of all, what do Alone do?
Yeah, so Alone is an organisation and it has been around for many, many years, but since 2021 has been part of the ECC programme. And we're a national organisation. Our work aims to support people to age well at home, fundamentally. So we've got a national network of about 250 staff and thousands of volunteers across the country that work with older people. And our work aims to improve their physical and mental health, basically. So we've a number of different services. I think a lot of people will probably be familiar with the support and befriending services, and they're volunteer powered, effectively. So we've got a telephone support and befriending service and a visitation support and befriending service. We also offer support coordination, and that is where an Alone staff member will meet with an older person and conduct a holistic assessment to identify what issues they're experiencing and work with them to find solutions to meet those needs. We provide assistive technology that keeps people safe and well at home, and we also have a national support and referral line where people can access just information and advice about supports for older people. They can make a referral as well. And we're an approved housing body, so we have over 100 tenants and they're all in Dublin actually. And we're involved now in delivering Housing with Support, which is a demonstrator project in Inchicore where we've got older people in independent living, but there is on-site support provided by Alone.
So there's a lot of different feathers to the cap there. And in terms of the traditional thinking, I think some people may think Alone is just for working with people that are isolated. Your remit is much broader than that.
Yeah, it is. I think there is that misunderstanding. About half of people who seek support from Alone report loneliness. And in general, 2/3 of people who come to our services live on their own. But not everyone who lives on their own is lonely. And likewise, not everybody who's living with others isn't lonely. We have seen over the past couple of years, as we have supported more people in their 80s and 90s, actually physical health needs overtake loneliness as the main reason why people are seeking support from our service. So a lot of the time with physical health needs, people are coming because of issues around falls or memory loss or, some kind of cognitive impairment. And I would say with loneliness, oftentimes when they present with loneliness, there are other issues that they are experiencing that we can provide support with, whether that is housing or it's a financial need or it's something around, utilities, energy poverty, etc. So I think coming out of COVID, we've been very focused on kind of scaling our services and bedding down kind of teams, etc. across the country. But there will be a massive focus in 2026, I think, in increasing the understanding of the breadth of the services that we offer.
Okay, well, hopefully this can help. And Gail and Catriona, can you give us a bit of insight into your work? You're both working as advanced nurse practitioners, but you're on the ground in Laois. Gail, can I start with you? Tell us a bit about your work.
Yeah, so our work is primarily in the hospital in the acute setting. So as everyone is aware, or as you may be aware, the populations worldwide are ageing, and that continues here in Laois. We're actually ageing 3% faster than the national average in here. There's also the aspect of people are living longer and they're enjoying healthy lives, but there's a certain percentage of older adults that are vulnerable, and relatively minor changes in their circumstances leads to a deterioration in their health and ability to live independently. In 2024 here in Portlaoise Hospital, we've seen 4,885 people over the age of 75 years. That's a catchment area of Laois, Offaly, Tipperary, Kilkenny, Carlow and Kildare. In order to address this, the Department of Health and the HSE developed Staunch Care strategy, which is to deliver the right care in the right place at the right time. And I suppose that's how our jobs came about in the acute setting.
There was a growing need.
Exactly.
Yeah.
for it.
From your perspective, Catriona, you're working in the same geography but slightly different remit.
Yeah, I work as part of the frailty team in Portage Hospital, based in the emergency department. So I look at frailty. So frailty is something that happens across the life course, but particularly older adults that are more vulnerable to it. So it can be less strength, less energy, less balance. It pertains to like how you bounce back from an illness. So as you age, that your bounce back ability is challenged by frailty. So that's where frailty intervention teams comes to address those needs identified within the emergency department. So I work with a senior physiotherapist, a senior pharmacist, and we have access to an OT, a specialist OT as well, if we require for our service. So we complete a modified geriatric assessment, and Gail has more information on the details regarding to a geriatric assessment, because it is actually the tool that identifies interventions that are required. It's how we find out, because it's not just how someone medically presents. There's all the psychosocial issues related to someone presenting, particularly as they age, and the social determinants of health. So the CGA is our key part. It's the gold standard in how we approach older persons' care.
The CGA?
The comprehensive geriatric assessment.
Oh, okay, yeah. So I presume that's sitting down with somebody and getting behind the immediate presentation, and the context that you're all after outlining really is about, as a response to this growing need, there's coordination between the needs. And Gail, tell us about that needs assessment that's getting behind what people might at first glance.
Yeah, so the research will tell us the most people want to remain in their own home. So in order to do that, the gold standard is the comprehensive geriatric assessment. So I'm just going to refer to it as CGA because it is quite lengthy in saying it each time. So the CGA is a person-centered approach. It looks beyond the single disease. But what we're looking at is we're assessing the medical, the functional, the social, and the environmental aspects of what's going on in a person's life, which our main aim is to develop and implement coordinated, integrated and timely plan for treatment, rehabilitation, support, and then the long-term follow-up that arises for this. And we do this by promoting healthy aging, and the most important thing is forging community links, because we can only look after them while they're an inpatient in the hospital. But the most important thing is the work that goes on at home then afterwards, once we coordinate that care and support, that we ensure that they're safe going home and that we keep them safe in our own home. So the CGA is actually a privilege to do. It's a really, really timely document. It takes about 2 hours to complete with each patient, maybe 2.5, depending on their ability to answer questions, and they can tire very easily. But during that 2 hours, what happens is we foster a therapeutic relationship where the person ends up building that trusting relationship with us, opening up and telling us things that they may not have said to anybody in years. It lets us build a platform for further interventions identified by that person to enable them to achieve their goals and wishes. And that's technically what it does. What we have found from doing the CGA is that when we give them the platform to talk, we have unraveled stories about grief, abuse, isolation, loneliness, the loss of their spouses, and how that's affected them and impacted them and made them not just physically lonely, but socially lonely as well. And we know from the research that this increases the risk of depression, anxiety, that further exacerbates their poor physical health. It can expedite cognitive decline and increase vulnerability to further stressors. So it actually has a huge knock-on effect.
That seems to be the richest part of your engagement, that starting point, the CGA. You're pulling apart the streams and you're offering a listening ear to an abundance of issues, but you're peeling away the onion to get at really what's going on. That must be a very sensitive time.
Extremely sensitive. It's a unique and privileged position that we were in when we're being told these stories. Like, we could tell you 100 stories here today about different situations that we've had an impact on through sitting and listening and carrying out the CGA. But through these conversations, it allows us to signpost to community resources that enables a person to get the help they need. Like, they might come into the hospital with one thing, but we can ensure then that the holistic person is looked at by integrating with our community supports.
And I suppose that's going back to, I know you referenced Sláinte Care and Aileen. Across the country, the work with Alone is trying to work with the Enhanced Community Care Programme, the ECC programme in the HSE, so that you're able to join the dots just in the same way that Gail is saying there. Isn't that the point of it?
Yeah, absolutely. Partnerships effectively are what it's all about. And so we have 12 teams across the country and a support coordinator in every one of the community health networks, or CHNs, across the country. And a big part of their job, and the manager who leads those teams, is to develop connections with other services and with other people like Gail and with Catriona in communities. So that if somebody comes to our service, we talk about bringing all other services and strategies through their front door, but really we're able to, link in with people and use our relationships to get people the best support.
So there's relationships between staff to build on the relationships with the staff and the patients. Can you give us an example of that, either Gail or Catriona or Aileen, from your own perspective? Is there anyone that kind of sticks out to you that might showcase for the listeners today?
Yeah, so one in particular was I was asked to carry out an assessment on a 93-year-old lady. It was her third admission to hospital in a relatively short period of time. She had actually been in hospital 3 times in 3 different counties. And this is what can happen sometimes. So that there's already a disconnect of care because we haven't got the full picture of what was happening. So even though she was a tiny little woman in stature and appeared frail, her personality and determination was a completely different story altogether. From the start of the conversation, we made it quite clear that she was going home and I wasn't going to change her mind, even though I had hardly got past the situation of saying hello to her at this stage. Everyone saw her as a 93-year-old lady and she was living alone and, she was after attending hospital, 3 different hospitals on 3 different occasions. So for her safety, without looking at her goals and her wishes, it was kind of like, oh, if she was in a nursing home, at least we as healthcare professionals would know that she was safe. But when I explained to her the goal of the CGA was to try and get her back to her own home and to keep her in her own home as long as possible, it actually opened the door for a conversation and she agreed to my assessment. So just to give you a little bit of a background, this lady lived alone. She was never married, went to mass every morning and she was involved in the choir. She had a really, really good social circle, so she was really, really engaged. But then in the last few years, she became less engaged. She had a niece and a nephew and some good neighbours, and the main goal for her was to remain at home. It was kind of so funny because when I was doing the CGA with her, she was telling me that her neighbour brought her dinner and she goes, I didn't like it. She goes, oh God, every day she brings me salmon dinner. And I thought it was fun. I was like, would you not let her know and just say that you don't like salmon? And she goes, oh God, I couldn't do that. She said, the woman bringing me dinner. So when I was asking the neighbour for the collateral, the neighbour goes to me, I'm very worried. She goes, I bring her up dinner every day and she doesn't eat it. And I didn't have the heart to tell her to eat her. So the two of us kept quiet in that front.
That's such an Irish example, Gail.
Exactly. It is.
It'd be rude to say the truth.
It was. And I telling her to say it and I wouldn't say it myself. And then we spoke and worked our way through the CGA. We identified a list of problems like her falls, her low blood pressure, hearing problems, medication.
Was it falls that was bringing her into the hospital visits?
It was, sorry, she presented on that day with a fall. She was found at home on the floor after a long lie. Medication compliance, isolation, and environmental issues. We were able to look at her falls and why that was happening. It was due to orthostatic hypotension, so we were able to rectify that. We were able to refer her to community partners like CHIME, which is CHIME, for her hearing problems. The HSE does have a waiting list. But through working with Catriona, who done a lot of work with community intervention team before I started in my role, she has ways and means around every long-term aspect of the HSE. And Chime is just one of them. It's an absolutely brilliant organisation. Medication compliance, we'd asked our pharmacist to review. The isolation and the environmental issues, thankfully we had a loan for these. So the isolation was identified as an issue, but as we spoke, I felt it was more an issue from my point of view because she said, well, I've actually given to my community. I'm happy to sit at home now and let people come into me. And the other thing then was her environmental issues. So her roof was actually half down on her home. There's age-friendly homes was developed by Sláinte Care and they have a brilliant setup. But one aspect that remains elusive is that the older person has to engage the quotations from tree builders in order to get the application for funding in to the county councils. So we were able to refer this lady to a loan who was able to coordinate the builders, and that way we're ensuring that a vulnerable person isn't going out and seeking quotes. You find that some builders didn't want to do small jobs, and then some builders were too busy as well. So alone we're able to coordinate the quotes for this lady. She ended up having her roof fixed. She went for convalescence while that was being done. She came home to her roof being fixed and the application for new windows in her home had already been commenced as well.
There's a lot of practical things there you're talking about, Gail. Aileen, what's your reflection on that example that Gail just gave?
About a third of people who come to us present with some kind of housing issue. And actually, like Gail mentioned, a lot of the time it's some kind of home adaptation. And actually, most of the time, it's a really simple bathroom adaptation.
Yeah.
So we have certainly had lots of stories of people just getting grab rails in or a walk-in shower. And that is fundamental, though, to their dignity and their independence and really enables them to age well at home. A big issue for us coming into the winter, and I suppose mindful of the time of year, is we do see a lot of people needing to stay warm at home, but with increases in cost of living, people are, they're going to bed early because they can't afford to turn on the heat, or they are choosing between eating meat or good food or paying an electricity bill. So a lot of the work that we're doing at the moment around housing is about, helping people with the utilities, maybe getting them registered as vulnerable customers. We have partnerships now with all the energy suppliers, so Electric Ireland, Bord Gáis, SSE Electricity, Prepaid Power, Energia, and each of those has hardship funds. So we're able to support people to access those funds if paying the bills is a problem for them. So certainly that kind of story, I would say, is kind of echoed around the country.
Like, I can just think that not paying a bill or saving, trying to scrimping and saving just to try and get by, it's getting in on your anxiety levels, it's your stress levels. It's sad to think people going to bed early because of the price of heating, but I'm sure that's the reality. You're not getting proper rest if you're living in that stressed state. And then just the other thing I'm kind of hearing, like that falls risk is massive for your population.
Yeah.
Like you said, Aileen, they're having an adapted bathroom or having grab rails and things like that. There's such simple, cheap resources.
Yeah.
That we should be nearly have a system. Everybody's going to need these.
Yeah.
But they're still not.
Many people don't realise that those benefits or entitlements are there, or they struggle to access them. And it is generally a problem that we have in terms of kind of social protection and those benefits and entitlements.
Yeah.
They struggle. There's 3 different forms, they're very long, there's a lot of detail required in some of them, or there are payments required up front for some home adaptations, or you require an OT report and you might have to wait a year to get that OT report. So I think we make it too difficult in general in this country for people to get those supports. That is something that we would be kind of in our policy and our advocacy work would be engaging with government departments and so on to try and highlight awareness of those issues and advocate for those people.
Catriona, what's your reflection on that?
Yeah, because that's why we use a loan, because we have found that we've met people that have actually fallen over the rails that were suggested because they had no one to put them up. Or that because there's an assumption of when you've had your assessment that they order equipment for you. But unless you have someone like a son or a neighbour that knows where these rails are to be put up and who's going to put them up, there is no one to put them up. Alone are who we call to advocate for people. So even though they're getting the services that are required, it's who's going to follow through in it, who's going to follow through on the pendant alarm, who's going to follow through on the window if someone had a fall and the door was broken in to get that person off the floor. I ring Onion alone to help navigate that scenario because the person in the bed is worried about is their house secured. Usually the guards are very good at securing it, but how are we going to get back into the house? How are we going to make sure that that door is fixed? Alone do that.
I would have never even thought of that.
Yeah.
So that happens every time there's a fall or somebody's found. Yeah,
and the likelihood, if you are someone that's had a fall and you're on your own, your family, you A, don't have a family that's close by, or B, you have nobody. So who's going to navigate fixing that door for you? And you're potentially 86. So alone is why we pick up the phone from the ED. Like we've built up such a relationship with our coordinators. If I've met someone that I know that I'd previously done a referral for, I'll ring up to see, look, did they engage before? Alone fix all that. Alone are the key people to advocate for those patients in the community. Post it, like I would say, we do the CGA, but the action of the CGA is what Alone and Age Friendly and all these community supports follow through on. We can identify it, but I'd love to be able to go out and follow everything through, but Alone embody our desire to fix the situation. That's the gist of it.
Yeah, that's very succinctly put. And the numbers that Gail highlighted earlier on, like it's a very significant population of older people coming in through the service for a variety of different reasons. I'm sure they don't all need different referrals, but oftentimes in my experience, when you have one complex need, there could be other needs. It's not always that one referral is going to do it for you. Catriona, can you give us an example from your experience of how the collaboration has worked effectively?
So I had a gentleman, an 88-year-old man who was asked to see, and the handover was he's very grumpy. doesn't really want to be chatting to anybody. He's just here for an x-ray. They didn't want to go to the GP, and they definitely didn't want to be sent into the ED. They don't want to be a bother to anybody. So I went down to chat to him. He was very well dressed, looked like really, really dapper. Snow white hair, glasses. He couldn't really hear. The nurses were having to shout at him.
Yeah.
The relationship had nearly broke down by that stage, and it was only in the place about 20 minutes. But when I got chatting to him, I explained briefly what I do, because I usually say frailty well into the conversation, because there's automatic assumptions with the word. So I charm people first, and I offered them a cup of tea or black coffee. He wanted some black coffee. He hadn't had any food since 6:30 when he left to go to the GP's. He had had a fall 4 days previous and it hurt his wrist. And he really wasn't bothered by it, other than he couldn't cook potatoes. And he found it hard to button his shirt. And when I say he was turned, he had a tie, everything on him. He was so dapper. But he was really sort of allergic to me sidling up beside him. But the tea and the toast sort of won him. And then usually I get everyone to go for a little walk, because then I can see how they're on their feet. We're chatting away, and I ask him what happened with the fall. I found out the fall happened at night time, and he was able to get himself off the floor. But he was on the floor a little bit longer than he had initially told the GP. And it was cold, and it was a hard floor. He doesn't have any carpet on the floor. And he doesn't have a pendant alarm. So this is where the conversations lead into. This is what is the value of the CGA. It gives us a checkbox as well for how we're doing the full psychosocial assessment. So he's really not warm to us at all. And I just said, what did you work at? And he was a retired sergeant. I understood then there's like a mistrustful, I don't want to be giving out my information. So then I tell him my daughter's applying for the cadets. Well, his eyes lit up, and he tore into the cadets, and he told me all the training, and they wouldn't be even training them as hard as he trained them, that they've made it all soft for them now. And that was the conversation breaker. So I always say, Gail and me are very lucky, we're very privileged, but we get to reach in.
Yeah.
Never is a situation just a fall. A fall is the red flag. There's so much more going on in that situation in the background. So the gist is, we had a great rapport then built up, and still wary of me. But he said he had known, all his friends had died, all his family had died. He was the last of his generation. He had one nephew that sent him a card at Christmas side and always gave him a phone call. But he didn't really have anything to do with him. He didn't even know how many kids he had. But his neighbour, who he identified initially was that he had no one that would look out for him, but actually his neighbour, who was 60, would drop him in dinner if he was unwell, would make sure in winter that he had enough fuel, would collect prescriptions. So even in that conversation, I was able to talk to him about, well, you actually have someone that's very good to you. You're not completely isolated in yourself. So even that perspective. And then I asked him what would happen at night time if he fell, who would you contact? And he actually didn't have anybody. And then he realised he always leaves his phone downstairs. We would have no way of contacting. So then we were able to lead into the value of the pendant alarm. And then I was able to talk to him, well, I have a girl out in the community who's chatty like me, would love to come out and chat to you. And maybe if you felt up to it, maybe the pendant alarm might be a good idea. And maybe we could talk to your neighbour, and they might be the person that would be your contact person. And because none of it was being pushed onto him, it was all being very much in his control, and there was going to be another person to follow him up. That alone, he didn't need to see a public health nurse. He didn't need to see his GP again. He just needed somebody to guide him as to what things. Now, equally, he was very hard of hearing, and he said, well, no one ever rings me, so I don't need to hear anything. And I explained to him the importance of your hearing for your cognition and for memory, because he's such a resilient person. He didn't need anything. But when I explained to him the importance of having hearing aids, I said, look, if I do the referral, I'll give them your number, but I'll ask the loan coordinator to help coordinate that for you, getting to the appointment, things like that. Oh, that was okay too. And then I dropped in the next bit, which is like my baby, thinking ahead, which is I love advanced healthcare planning when people are well. After COVID, it just was a very stark reminder we need to make these plans when people are well, not when people are really unwell.
That's the Advanced Healthcare Directive, yeah.
We coordinate with our coordinators in Laois that they would be the secondary person that would follow through. Because a lot of times we can give lots of information, but it's who is the person that's going to signpost when you leave the hospital, that link in the chain to how do we make sure that this happens, that people get to fulfill, particularly someone like him that doesn't have anyone that knows his wishes. If we do our job well, when these crises happen, all these things should be in place in advance of the crisis. You can't avoid a crisis. They're going to happen anyway, but how can we make them as simple as possible for people out in the community and in the hospital?
Yeah. It seems to me that from both those examples, I'm sure there's lots of other similar examples, but it's about your valuable time and you looking for a frame of reference there to be able to latch on to even the training piece, or him being a former sergeant or whatever. Any way you can get into a conversation and build up a bit of a trust, and then you got your successful referrals or put a few things in place for him. Even that conversation, like it sounds like going through that assessment, you're leading the thinking on different things. You're talking about risk reduction. You're nearly prompting areas for their reflection that'll reduce risk. That phone been left downstairs, like that's such a simple thing, but Is it easy to get people to take on those alarm pendants that you're referencing?
Particularly, I think with me in the ED, it's a little bit more challenging because I get to meet them very briefly.
Yeah.
I think sometimes if you get a longer time to have a rapport, so it's so important. Like I would get a lot of collateral and I would let family members know, well, I've had this conversation. This is really important. This is who you contact. And this is where alone are the key peak because they are your prompt when that person leaves. Like we would put it on our referral, the key points that we want reiterated. Sometimes there's a thing called XWell that we would advocate for our patients to access to. But obviously if they've been unwell and they've had a fall and they're going to community physio, you want all of that to be resolved before you refer to XWell. I would have that on the referral to the alone, prompt in about 3 months' time if they're still engaged with you to maybe go back to the GP for their XWell referral. So it's all of that secondary link because just all the services are so stretched. And alone, as I said, it's the action of what we identify within the CGA. Like it's the only way, and we use everything. Like we're communicating out to everybody all of the time. And equally, if they have a question, they can come back to us, like about somebody or another service.
Aileen, I suppose when you consider the HSE services, they're often the first door, but there's limitations. So we need community-based supports. What's your reflection on that example there, what Catriona's been talking about?
Yeah, that is effectively why Alone is being funded as a core part of the ECC programme to work with others in the community and in the acute setting to do what Catriona's described. And this year, I think across our services, we'll have supported 46,000 people. So to kind of the earlier point around the ageing population in Ireland, the demand is certainly there in our services as well. Just something that's important and struck me when Catriona was talking is just to say that we've no eligibility criteria really other than we support people aged 60 plus and anyone can refer. So most of our referrals come from health professionals and from HSE colleagues. But older people can refer themselves. Family members can refer or somebody else in the public, extended family, etc. Although I would say at the moment about 2/3 of our referrals are coming from professionals, health professionals.
The information that you're highlighting today would be very important for people working or volunteering in the health or social care arena. And then obviously from loads of people have vulnerable members of their families that they're not near or they can only support so much. They do need extra support sometimes.
Yeah, I think that was the other thing that struck me when Catriona was talking, the value of the volunteer. There can be a misconception that the volunteer is just there for the tea and the chats, and that is a huge part of what they do. But it is that practical support. If somebody falls, they might be able to pick up the shopping and bring it to them, or they can coordinate filling in forms as appropriate. Sometimes the volunteer is the first person to spot something. And they're able to link them back in. We've got an app for them, and within 24 hours, they'll get a response from an Alone staff member, a support coordinator. So if they spot something in the home or, there's an issue with an older person, they can get support for them quite quickly. Our volunteers, the ask is to stay 6 months or a year. Oftentimes people stay longer. They seem to get enormous benefit from it. It is hugely rewarding. We're always looking for volunteers. The numbers continue to grow, so there are people interested in it. A lot of them are older people themselves. And actually, we have a lot of volunteers who are also working in healthcare settings. I met somebody recently who was saying, oh, yeah, our senior social worker is a volunteer with Alone, which is great.
Wow. Of course, volunteering is a health-enhancing activity.
Yeah.
But it's got that multiplying effect if you're able to support people like you're saying there.
Yeah.
Okay, Aileen, I know you sent us on the Transforming Ageing at Home report. What were the main findings of that report? That was an Alone report on some of the work here.
Yeah, so we published that report in June of this year, and we have an in-house research and evaluation team that worked on that project with health economists at the London School of Economics. So it was an 18-month project. We had a group of 273 older people who we followed over 6 months. So there were actually 182 of them who stayed with us for the 6 months. They filled in questionnaires with questions about themselves, their levels of loneliness, their well-being, their personal capability, which is your ability to live the life you want, really, which is a lot of what we're talking about, their quality of life, and then how frequently they were using other healthcare services. So mirroring people who would generally come to Alone, the slight majority of them are female and most of them were living on their own. About 96% of them were on some form of daily medication and most had a health condition. What we saw reaffirmed, I think, what a lot of us in Alone and others who are familiar with Alone would know, which is that the group of older people were using health services a lot more frequently than the average population. So if we were to compare their profile to, say, TILDA, which is our national longitudinal study on ageing in Ireland, or studies like TILDA in other countries. So they were going to the doctor 2 times more frequently. They were going to the emergency department 7 times more often, just as an example. And their levels of loneliness were 1.5 times higher than what we'd see in the general population. But over time, what we saw were reductions in loneliness, improvements in their quality of life and in their personal capability, and reductions in their use of community services and of calls and visits to ED services. And that then translated into cost savings as well, which I think was really important. But for us, we were struck by the fact that this group are facing, far more difficult circumstances than would be the average. And there's a really important preventative piece in it, because over time, what you'd be really likely to see there are just more declines in quality of life and in loneliness and so on. So we saw particular improvements for people who were receiving the support and befriending services, which is no surprise, because going back to the earlier point, it's really the value of the relationship that people have with the volunteer and with the staff member as well that is often central to the kind of impact that the service can have on their lives.
So that was very affirming of the direction and the collaborations that you built up. Can I ask you, what are the important messages for people working in the health and social care arena? We just referenced there that they'd be interested, they're working with people, or maybe they can see somebody vulnerable in the community. What message would you give them around the work of Alone or the work of the health service, either through the ECC or otherwise? Catriona, is it okay to start with you?
To listen and witness to someone's truth is very valuable. So I think we need to acknowledge that as healthcare professionals, it is a very privileged time. And I know time, resources and our own time is precious, but I think in line with making every contact count, we should be reaching in to try and solve these issues that are beyond what the initial presentation may be. And I think that's why IGPOP and all these hubs are going to be phenomenal out in the community, because they'll be able to support people, hopefully increasing the services out in the community, but also avoiding the hospitalisation and the hospital presentations in the future. So I would think pick up the phone if you're a family member or you're a relative of somebody or a neighbour, ask them, are they happy for you? But get advice from Alone as in what's available and how to then, if you have somebody that is maybe a bit wary of healthcare services, Alone will be able to navigate that to help you let them know who is the appropriate way to break down those barriers in the community, particularly if you're in a community and you notice there's somebody struggling that is not engaged with services. Alone will give advice as to how to even get around those challenges.
Aileen?
Look, we have an Asian population. As Gail mentioned earlier, most people want to stay at home or as close to home as they can be. And we'll always need nursing homes, but a lot of the time I think people end up there unnecessarily, and people deserve to be able to stay at home, and it's just hugely important. I think partnerships to support people and that proactive piece Catriona mentioned, a lot of what people need and want we can address, we can solve by working together. So I think I would echo what Catriona said in terms of accessing Alone, and certainly our National Support and Referral line, that's 0818 222 024. If there is anyone listening who wants to access our service, is really important. But the coordination piece and the partnerships and the working together, I just think, is what will get us all there.
Gail, last word with you.
Well, look, as you know, from what we've been speaking about today, we cannot praise or sing the praises of Alone enough. To be honest, one of the things that I wanted to say was there are actually eyes in the person's home, because we can do everything that we want to do. But when we ask Alone to go in, we always ask them to do an environmental check. Fergal, you wouldn't even be surprised by this, but some patients don't even turn on the lights or have light bulbs in all the room. There might be mats that are in the bed. By asking Alone to do that environmental check and just see what's going on in the home, it allows us greater peace of mind. They have absolutely been brilliant to our service, and we know by using Alone that our patients are safe in home, because they're going in the interim. They're not replacing the service, but they're keeping our patients safe in the meantime. And what more could you ask for, really?
Yeah, that's a very good way to sum it up. Well, Lucas, I really appreciate your time coming in remotely for this podcast recording today. Catriona Brennan, Gail Flynn and Aileen O'Reilly, thank you very much for participating today. And to the listeners, I just want to highlight that number that Aileen called out there. We'll put that number and the website, the Alone website, into the podcast information section. Wherever you're listening to this, you can get those referral points. And I'd like to thank you for listening to another episode of the HSE Talking Health and Wellbeing podcast.